So thank you all for joining the third annual Ashok Gupta Memorial Lecture in Parkinsonian Disorders at here at UVM Medical Center. My name is Deepak Gupta. I'm Ashok Gupta's son, and I have tried to organize it now for the third time in a year. So I just want to take a couple of minutes to talk about my late father before we introduce our visiting speaker, and then obviously then hear the talk we have lined up today. So hopefully you have gotten the brochure, which sort of talks briefly about him, but I thought I would take a few moments to talk about him. He passed away. The punyatithi here is the Hindi word of, when he passed away on 21st of April, 2021. So he was born in a small rural place about, 15 miles from New Delhi, called Kekra, in July. And he was as a person, he was a son of Mrs. Ram Devi and Mr. Suresh Chandra Gupta, and he had three siblings. He was husband of my mom, Ms. Sudha Gupta, who lives in Delhi. He was father of my older brother Vipin, myself, and my older sister. That's a huge typo right there. Older sister Anjali. And he was father-in-law of our spouses, Sanjeev, Neha, and Rashmi. And he was also the dad of, six grandkids, grandfather of six grandkids. And he did quite a bit of education, especially coming in from a relatively poor family. His father was like an owner of a sweet shop in that village. He was, I think, the most educated out of the whole extended family. He did high school, bachelor's of art degree in 1975 from Meerut University and Master of Economics degree in 1977, as well as another bachelor from University of Rajasthan in education, which is what he pursued all his life as a high school teacher. And he was a religious and family man. And he was also a Parkinson's disease patient for over 13 years. And in my view, he was alive for like over 64 years. So that I'll make it brief and not too emotional. But the only thing I will say, this lecture, I always say this in this lecture for 2 years now, is my opportunity to bring him here, visit me, because he could never visit me in the States in his life. So that was one of the biggest motivation I had in setting up this lecture for him. It gives me a time to reflect that he's probably visiting me. And I just want to take a moment to acknowledge our chair, Gregory Holmes, and my division chief, Dr. Boyd, who have enabled this lecture to happen in first place. And they help support it along with the foundation I've set up in his memory. With that, I'll request Dr. Boyd to briefly introduce our visiting speaker, Dr. Hiller.
Thank you, Dr. Gupta, and thank you for supporting this lecture. I think it's a great honor and a memorial for your father, and always exciting to get great speakers to come in for it. So I want to introduce Dr. Hiller. She comes to us from Portland, Oregon, at OHSU, the Oregon, I'm going to make sure I say it correctly, the Oregon Health and Science University. Yeah, I know. That's why I was just making sure. Where she's an associate professor. She is the director of their PADRECC, which is the Veterans Association Parkinson Center for the entire Northwest, which is and that spans really an enormous territory. So Amie and I met when we both got our Mentor Clinical Research Awards from the Parkinson Study Group and the Parkinson Foundation. So her pilot study of looking at the impact of vitamin D on balance in Parkinson's disease was just a couple of years prior to my first award, which we met and stayed on a committee together. This was back in like 2010, 2011. And so it's been really great to watch her career kind of take off. And she followed that up with some work in intervention with using vitamin D as an intervention to try to improve balance, and did a multi-center study with that as the lead investigator. But we're delighted to have her come here today and talk a little bit about the newest criteria and biological basis for the diagnosis of Parkinson's disease. So thanks for making the trip. It's great to have you, and we look forward to your talk.
Thank you very much. Can everyone hear me okay? That sounds pretty good. Okay, great. And And then I'll need to switch to my slides. Is that right? Or if I just go forward, will they show us? This one. Okay. Okay.
Actually, I should fire your PowerPoint.
Yeah, that's what I was gonna say.
Yes, that's right.
And then what time are we finishing up?
I think we can go until almost until 1.
Until 1. Okay, great. So you already know who I am. I'm going to talk about redefining Parkinson's disease and talk about a new staging and classification system. I'm going to give quite a bit of background on it. This can be a bit of a dense topic. I talked to my division head beforehand that I was planning to put together this talk. I gave it for grand rounds on Wednesday of this week to practice. And when I told him, he was like, oh God, that sounds so boring. And then I told my husband, who is a philosophy professor, and he was like, staging, classification? That sounds fascinating. So it may depend on who you are or where you align with this. As we get into some of the nitty gritty, that may be a point, especially for patients in the audience listening, that may be the time to take a little quick restroom break if it's feeling a little too dry. But I think we do have to get to some of that. But I'll give quite a bit of background for those who are movement disorders and non-neurology people too. So I'm going to talk going to go over my objectives quick. So to try to know some means of identifying alpha-synuclein in living persons, we'll talk about what alpha-synuclein is more, and then to be able to name 3 of the categories proposed in these new classification systems, and then identify at least 2 of the most common genes that can cause Parkinson's. So this was our original introduction to Parkinson's. This was from James Parkinson many, many years ago, 1817, it says down there. And he didn't do such a bad job. He said, involuntarily tremulous motions with lessened muscular power in parts not in action, and even when supported, with propensity to bend the trunk forward and to pass from walking to a running pace, the senses and intellects being uninjured. So maybe missed a little bit at the end there, but otherwise we did pretty darn well. I think also in talking about this, it's good to just go through some brief definitions. So a disease is a deviation or disorder in normal functioning resulting in specific symptoms, physiological abnormalities, or pathological state change. Disease classifications are systematic categorization based on various criteria. Disease staging are categorization and classification of the extent or progression of a particular disease. And then rating scales are standardized measurement instruments to quantify or measure aspects of health, symptoms, functioning, and disease severity. So basic outline, I'm going to go through the current diagnostic criteria. Then I'll review a bit on alpha-synuclein measurements, imaging tools in Parkinson's, and genetics in Parkinson's. Then I'll go through the current staging system. That's one slide because it's pretty basic. And then I'll do an overview of 2 new classification systems that have been proposed, and then do a little commentary on those 2 new systems. So current diagnostic criteria. So this is just kind of a picture of how we think about things these days. We think about, does someone have Parkinsonism, some symptoms that look consistent with Parkinson's? We kind of take out some of the lookalikes usually pretty easily after we do an exam, and then we think, okay, this might be a Parkinson's syndrome. Is it Parkinson's disease? And if we go down that path, then we think about sporadic or genetic. If we go down the other path and think about other things, do we think about atypical syndromes? These are kind of what I call the alphabet soup of movement disorders. So multiple system atrophy, known as MSA, progressive supranuclear palsy, known as PSP, CBD, known as cortical basal degeneration, and DLB, known as dementia with Lewy bodies. And then we've got these other things as well that can look like Parkinson's, vascular Parkinsonism, drugs that block dopamine, which are called neuroleptics primarily, and then a few other less common things. So we're really starting with the clinical symptoms and then kind of figuring out what we got going on. And the motor symptoms of Parkinson's, I think most of us are probably pretty familiar with this. We've got stoops, posture, mass facies, rigidity of limbs and back, reduced arm swing, tremors of the hands, oftentimes the legs as well, flexed knees and hips, and short shuffling gait. And those motor symptoms are just really the tip of the iceberg. I'm going to have kind of a snow theme as I go through this, which maybe not appropriate for the time of year, but probably appropriate for Vermont. So I'll just stick with that. So the tip of the iceberg are these motor symptoms. Those are oftentimes more obvious, what we see, but there's a lot of things that we don't see. So anyone with Parkinson's is aware of this: constipation, speech, swallowing, sleep problems. You can read the list. There's a lot. And not everyone's going to have all these features. So we'll often say people with Parkinson's are like snowflakes, that everyone's a little bit different. So one person may have a lot of sleep issues and a lot of tremor. Somebody else may have no tremor at all, and their sleep may be fine, but they may be slow and stiff. So this is, I think, part of what makes things complicated, because you can't just have boom, 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 it's Parkinson's, we're good, no questions asked. So reviewing the most commonly used clinical criteria that are available now, one of the big things about that is their clinical criteria, right? So these are all based on symptoms, and I'll go through a little more in depth than the big ones. So this is the UK Brain Bank clinical criteria. This is really one of the oldest, and there'll be a common theme here in how they're presented is that we have the Parkinsonian syndromes. Bradykinesia, or slowness of movement, is one that we need that. If that's not present, they don't have Parkinson's. And then they have to have a second symptom as well. And then we've got some exclusion criteria. We largely think about these for those atypicals, that alphabet soup that kind of puts us potentially in that camp. And then there's some supportive features that help us say, okay, yeah, we're fairly sure this is going to be the diagnosis. This is a more recent classification that came out from the MDS. MDS is the Movement Disorder Society. That are a big kind of overarch within movement disorders and Parkinson's care. And this came out in 2015. And I like the visuals here. So you have one side with the green boxes there, and then the red boxes. You don't need to look at all the details. But basically, if you've got more greens and no reds, you're going to be tipping the scale towards the cis Parkinson's. If you've got more reds than greens, you're going to be thinking generally it's one of these atypical syndromes. In addition with these, because they are newer criteria, there are a couple tools put in that weren't in older criteria. And we'll talk a little bit more about scanning, but supportive criteria with this could be an abnormal MIBG scan, which I'll talk a little bit more about in a minute. And then red flags would be having a normal DAT scan, what we call a DAT scan. So if it looked like the dopamine system was intact, that would be a red flag that this isn't going to be Parkinson's. Okay, and then the Gelb criteria, this one's a little bit different. Again, we're looking at things that you expect to have, things that you wouldn't expect to have, things that would be kind of helpful if you do. And they divide it into possible, probable, and definite. And the important thing with this one is this definite is based on pathology, so what we see in the brain. So this is kind of the classic findings that we see in the brain, the Lewy body, and the Lewy bodies are made up of alpha-synuclein, and this will keep coming forward. For people with Parkinson's, we don't do brain biopsies. I think most of you know that to make the diagnosis. I've had multiple times in the past where I would put probable Parkinson's in someone's chart, and the coder would say, no, you need to say it's definite Parkinson's. And I'd say, well, unless they have passed and I've done an autopsy, I can't say that it, definitely was Parkinson's. Now I think I say they carry a diagnosis of, since it's a clinical diagnosis. But this is, so you've got these criteria, and then definite was this pathology after someone passed, in cases where an autopsy could be done. So certainly a minority of patients with Parkinson's, we would be saying they have definite Parkinson's disease. And then the success of our diagnosis, there's lots of variability depending on the study, the criteria used, the stage in the diagnosis, who's making the disease. Probably when you're using older criteria with general neurologists, people are right about maybe 70% of the time. With the movement disorders, with the new movement disorders criteria and movement disorders specialists, we're probably getting closer to more than 90% accurate. So we're doing better. And then in terms of what we see with Parkinson's over time, is that we see this dopaminergic neuron loss. So this loss of dopamine neurons is really what we think the hallmark of the disease presenting is. And this happens for many years before we start to see clinical symptoms. Probably once we get to about 50 to 60%, we're starting to see clinical symptoms. And oftentimes people start with non-motor symptoms that can be very non-specific, like mood changes, changes in sleep. And then we often start to see some motor dysfunction. And then people will get a diagnosis. One thing you'll notice with this, talked a little bit about alpha-synuclein, which I'll talk more about. There's no alpha-synuclein or Lewy body on this picture. So we really think of this progression of disease being related more to this dopamine loss. So alpha-synuclein is kind of a marker, but it's not necessarily a marker of progression, which is part of why things are complicated again. And some of the thought is if we can intervene earlier on in this picture, we may have better benefits and prevent people from going on to develop Parkinson's and to develop worsening symptoms. Okay, so talking about alpha-synuclein measurements. So this is from April of 2023, so fairly hot off the presses, that we had this new biomarker found for Parkinson's disease. This is from the Michael J. Fox Foundation. This was the big paper that came out in Lancet Neurology in 2023. And it's this special seeding amplification that was done for alpha-synuclein. So what happens with alpha-synuclein? So we have this protein, it makes these longer pieces called monomers, and they come together and form oligomers, and then fibrils, and then Lewy bodies, and then those accumulate in the cells. So what they do with this seeding is they're not looking at brain tissue. This one was specifically done in cerebral spinal fluid, but they can take some of that fluid, add this seed, and then wait, and it allows for amplification and these fibrils to form, and now they can measure alpha-synuclein more accurately and sooner in the cycle of things. So there's two main ways to do this. One is through cerebral spinal fluid. So this is with a lumbar puncture where a small amount of fluid is taken out from around the spinal cord. This was the largest paper that came out, is really kind of the most accepted technique. And then more recently, becoming more common is a skin biopsy, where they can take a little small punch biopsy in multiple places and then do the same amplification with this. Okay, so this kind of turns things on its head, right? This snowman's now being turned upside down, that we could potentially measure this alpha-synuclein before someone's going on to develop symptoms of Parkinson's disease. So another tool that we have is imaging tools in Parkinson's disease. So the most widely used one is DAT scans. These were approved in 2011 by the FDA, and specifically to differentiate essential tremor from Parkinsonian syndromes. This does not distinguish between different Parkinsonian syndromes. So that alphabet soup, most of those are going to have an abnormal DAT scan. So this is a piece to help you, but it doesn't help you fully. So this shows a normal DAT scan, and we see kind of this comma shape. And then in the red over here, we see an abnormal one with Parkinson's disease, which tend to have more of a round shape, and usually they're asymmetric with one side being worse. There's also FDG PET scanning. This is much less widely available, requires quite a bit more interpretation, but this can often distinguish between this alphabet soup. So another tool in our arsenal, but not one that's as readily available. And then finally, this is actually a cardiac imaging tool that can be used. It's called SPECT-MIBG. And this can help distinguish dementia with Lewy bodies and Parkinson's from atypical syndromes like multiple system atrophy or progressive supranuclear palsy. This has quite a few caveats with it. There's situations where it doesn't work. It can be, again, kind of location dependent on doing it. And there's other reasons why it can be abnormal aside from just Parkinson's and Lewy body dementia. Okay, so I think with, again, patients kind of being part of this, and maybe just for general knowledge, I liked this article that came out from Michael Oken in June of 2023. Do I need a skin biopsy or DAT scan for my Parkinson's? And the spoiler alert was, if you've already got a diagnosis of levodopa responsive Parkinson's, you don't probably need a skin biopsy or DAT scan. So that, if we're really sure clinically, these tools aren't really that helpful. These are helpful either we're thinking to diagnose it earlier before we're really seeing symptoms, or in those cases where we're like, I'm not quite sure, could it be this or could it be that, when we're kind of scratching our heads. Okay, and then going on to genetics. It was a 2020 paper, I believe, that came out. I can't remember if it was the 2020 or 2021 that this one was from, but this shows the genes that we are aware of related to Parkinson's disease, and GWAS are these huge genome-wide association studies and pre-GWAS. We had quite a few genes. Once GWAS came in, we got quite a few more. And then the number of GWAS studies that we've seen over the year have just exponentially grown. So 2009, there were 3 GWAS studies. And in 2019, there were 90. So this is really becoming more available with time, and we're finding new genes. And then if we look at studies together now, for the average person walking into the clinic, up to 15% of people will have one gene, a monogenic pathogenic variant, that's going to predispose them to Parkinson's. This range is probably 10 to 15%. And then in some populations, very restricted ethnic groups, maybe up as high as 40%. So we used to say, you don't need genetic testing in Parkinson's. It's not worth doing. There's, it's like a needle in a haystack. But that's changing somewhat. And again, that's important for these classification systems. The other thing to know about genetics and Parkinson's, I think that's important, is we've got some genes that are very common. So LRRK2 and GBA are the ones that we see quite commonly, that have, as I should say, moderately common. They're not extremely common, and those have a medium propensity for people to develop Parkinson's. So just because you carry one of these genes doesn't mean you're going to get Parkinson's, but it means your risk is going to be quite a bit higher. We've got some very rare genes that chances are pretty dang high you're going to get Parkinson's. And then we've got a lot of genes, 90 variants, these are much more common in the population, that increase your risk just a little bit. So again, it's complicated, right? It's not super straightforward. And then moving on to review the current systems, this is to review the current staging system. So staging, we're looking at the disease progressing. So there's a scale called the Hoehn-Yahr scale. It's only got 5 stages. The first stage is that you have symptoms on one side of your body. It's not uncommon, but by the time we're seeing people in our clinic, they're already at stage 2 with symptoms on both sides of their body. So this is a pretty small group that we see at this stage 1. And then after stage 2, we really move towards things being largely due to balance and gait impairment. So stage 3 is that balance and stability become affected. And then stage 4 is an increase in symptoms, but people can still stand and walk. And then stage 5 is that they need assistance with everyday activities. And we often think of it kind of being somebody who's more in a wheelchair bound kind of stage. What would be considered a staging system today? This wouldn't even qualify as one, but it's what we have. And it's probably not going away anytime soon because we don't have a lot better. But if you think about that tip of the iceberg, there's a heck of a lot missing here, right, in the under part of the iceberg. So it's useful. We're using it, but we could do a lot better. Okay, and then to go over the 2 new classification systems. So one is called the Biological Classification of Parkinson's Disease, the Synergy Research Diagnostic Criteria by Hoglinger et al. And these were both published in the same Lancet. And then a biological definition of neuronal alpha-synuclein disease toward an integrated staging system for research. And that was by Simunian et al. So the first one, the Synergy, it's kind of nice. They came up with a catchy title, which makes it easier to talk about. This is focused only on diagnosis, and there's nothing about clinical staging. So it's just diagnostic. The article is also described as a personal view, which I think is important. Obviously, more than one person wrote it, but this wasn't a big group convened to come to this discussion, or at least they don't state that in the article. There's 3 components plus kind of a separate clinical component. So the 3 components involve alpha-synuclein, whether or not it's present, neurodegeneration, whether or not it's present, genes that put people at risk for Parkinson's, and then there's this kind of separate clinical component that looks at single high specificity features or multiple lower specificity features, and I'll go more in depth here. So this is getting about the time if you need that bathroom break, and this is feeling too heavy, you might want to take it. So to go through each category a little bit more in depth. So this is the synuclein, and they call it S, and then a plus or a minus if there's synuclein present. And they specifically go through different options of how to measure the biomarker and whether or not they endorse this. So they do endorse the seed amplification that we talked about in CSF. So that's definitely the most highly tested one, I think, highest sensitivity and specificity. It can actually distinguish Parkinson's from multiple system atrophy. So this one's pretty well thought of across the board, I would say. And then they do also endorse the skin with the seed amplification, which is a little less robust. And then they do also support some other skin testing with immunohistochemistry and immunohistofluorescence. And then there's these other investigational methods. I think the one people are most excited about is plasma or serum blood, which is much easier to get than other things. But there's not yet sufficient evidence for those, so they don't support those yet. And then there's times when you can exclude the synuclein piece if you contribute it to something else. So if you're pretty sure someone has multiple system atrophy, then you can exclude this, and this could be done either with neuroimaging or elevated neurofilament light chain. Okay, and then the N, this is the neurodegeneration piece, and we say it's either a plus or a minus. So they do have neurodegeneration or they don't have neurodegeneration. And the things that they endorse for demonstrating neurodegeneration are this PET scan, which the STAT scan that we talked about, Neurologic PET or SPECT, and then FDG PET, which we talked about, and then these MIBG scans as well. And then there's a number of other investigational things. And then again, you can, in certain cases, rule it out if it's clearly another disorder. And then the last one, this gets a little more complicated. We've got, as well as superscripts, we've got subscripts here. This is genetics. And in the genetics, there's either you don't have genes, you have fully penetrant genes, which they base as an F. So these are high risk genes. And then you have partially penetrant genes, which they base as a lowercase p. And they endorse quite a few genes as fully penetrant, the SNCA in a couple of forms, Parkin, PINK1, and PARK7. And then they have another quite a few that they do as the risk, including the GBA and LARC2, which are much more common ones to see, and then have some as investigational. And both of these systems, the idea is that these are going to change over time, and like the main categories are going to stay the same, but what you could use to fulfill those categories is going to change as we learn more and get more information on things. And then this is the clinical features. I won't go into this a ton, but they do kind of look at this separately, and they name some motor features, sensory, autonomic, sleep, and cognitive features that can put people into certain categories. And then kind of putting it all together, you have to have some of those markers and some of the clinical, and then you can get into C possible or C probable. I'm not going to go into this in great depth either, because I think the next slide kind of shows it a little bit better. And for each of these features, we want to make sure any of the clinical features have to be in temporal evolution in Parkinson's. So if someone had prostate surgery 20 years ago and has had urinary symptoms since that time, we're not going to say they've got urinary symptoms because of Parkinson's with the rest trauma that they've had for 6 months, right? So, and I think we're used to this in criteria. So looking at some how you would classify certain types of Parkinson's. So sporadic Parkinson's, we would expect that they wouldn't have a gene. They would have synucleinopathy being positive and neurodegeneration being positive. If they've got a synucleinopathy but are not yet symptomatic, we'd expect we could maybe measure some synuclein, but that we wouldn't see neurodegeneration yet. And then if there's some forms of genetic Parkinson's that do not have synuclein. So this is one of those, like, there's lots of asterisks on things, right? So they could be gene negative or positive synuclein negative, and then we could see evidence of neurodegeneration. And then there can be cases where there's going to be no evidence of Parkinson's. So we're not going to see the gene, we're not going to see synuclein, and we're not going to see neurodegeneration. And then, oh, and I'm sorry, I said this one wrong. This was non-Parkinson's neurodegeneration. The genetic Parkinson's without the synucleinopathy is down here. And so then we're going to have people with genetic Parkinson's with high penetrant genes that are going to be GF positive. Probably early in life, they're going to be S negative. They're not going to have any synuclein. And then at some point, they're going to transition to S positive. And then at some point, probably after they become S positive, they're going to become N positive, but there's going to be neurodegeneration that then is going on. And I won't go more into the specifics there, but hopefully that kind of plays it out. And this is how they kind of show it graphically, is that, again, if you've got this fully penetrant or this predisposition, this is going to be something that's constant over time. You're going to have this risk factor, or you're going to be genetically indeterminate, and that's going to be there, again, forever. We would expect with a synucleinopathy that early on, everybody's going to test negative, and eventually most people will become positive, unless you've got one of these synuclein negative Parkinson's diseases, and then you're going to stay negative all the time. And then we'd expect for everybody with any sort of Parkinson's disease that they're going to start without neurodegeneration, and then that's going to accumulate over time. And then we'd expect that the clinical signs and symptoms are also going to progress over time. So a lot of these people are going to be clinically negative, and then as symptoms start to show up, everyone's going to move into clinically positive. So the clinical stages, the clinical stage including all stage, so they just say no or yes, and they don't have a distinction between prodromal and defined disease. And they do look at both the motor and non-motor symptoms. Okay, so moving on to the next category, or the next proposed system. This is the NSDISS, which stands for Neuronal Alpha-Synuclein Disease Integrated Staging System. Doesn't roll off the tongue quite as well. This one did include a big working group. They also had meetings with stakeholders. So this one seems like lots more input went into this one. The big kind of excitement buzz about this one is that they're lumping Parkinson's and Lewy body dementia together. So they're looking at alpha-synuclein as kind of the starting point. And they contain both diagnosis and staging systems. I'll talk more about the staging system, but it's very in its infancy. They have two biological anchors, neuronal alpha-synuclein, and then instead of neurodegeneration, they look at dopaminergic system, but it's really pretty similar. And then the clinical stuff goes from 0 to 6, and I'll talk more about that. So the biological anchors, so they have their S anchor, which is neuronal alpha-synuclein. They only endorse CSF alpha-synuclein testing with the seed amplification. They say other tests may become appropriate down the road, but for right now, this is the only one we support. And part of that is because it can distinguish idiopathic Parkinson's from multiple system atrophy, or idiopathic Parkinson's and Lewy body dementia for multiple system atrophy. And then they call this an S1, or sorry, S positive if people have alpha-synuclein. And then their D anchor is the dopaminergic neuron system, and they call this D positive if people have evidence of dopaminergic dysfunction. And they just talk about using DAT scans for this. So that's the only one that they endorse. Their hope is that over time, the anchors will become quantitative. They are not right now. And then they also think that additional anchors might be added over time. As I said, alpha-synuclein is a piece of things, but it's not the only thing, and especially in disease progression, it's not the only thing. So I think the idea that we're going to need more as time goes on and we learn more is very appropriate. Genetics are looked at really separately and not really part of the system. They both refer to genetics with a G and with a risk in the paper, with an R for risk, and then they either define it as a high or low genetic risk based on, is it a high risk gene or is it a lower risk gene? I'm going to take a quick sip of water before I go through this one. So the staging is based on the clinical symptoms, but also incorporates those biological anchors. So the symptoms and impairments can be motor or non-motor. Stage 0 is that there's no symptoms. Stage 1 is that there's pathological changes, but no signs or symptoms. So those presenting with symptom stages. And then stage 2 is that we see changes, but only subtle signs or symptoms and no functional impairment. And then stage 3, again, those changes are going to be carried forward with slight functional impairment. Stage 4, mild functional impairment. Stage 5, moderate functional impairment. And stage 6, severe functional impairment. The categories are not defined beyond that. So what slight is, what mild is, what moderate is, what severe is, have not yet been defined. It sounds like that's being worked on, but it's not presented in this paper. So these are kind of a construct to then move forward with more of a staging system down the road. And this is it presented graphically. So again, there's these risk, which are your genetic state. So you've got the RL if you've got a presence of a low risk gene, and an RH if you've got a presence of a high risk gene. So this could be at any point in your lifetime. You could be tested for this and know that you're falling in one of these categories. And then stage 0, they're only saying would be this one variant FNCA that is fully penetrant. Everyone goes on to Parkinson's. There's no question, and no one else would fall in stage 0. And then stage 1 is you have alpha-synuclein pathology and dopaminergic dysfunction. If you have stage 1A, you just have the synuclein. If you have stage 1B, you've got the synuclein and the dopaminergic function. And then stage 2 is when you start to see clinical signs and symptoms. And 2A would be that you have alpha-synuclein and clinical signs and symptoms. Stage 2B would be that you have alpha-synuclein and dopaminergic dysfunction and clinical symptoms. Okay, and then stage 3 to 6 is where you're starting to see these functional impairments. And then looking at just slightly in another graphical way, so they use someone who's got a fully penetrant SNCA variant. We would expect early on in life, if we tested their alpha-synuclein, it would be normal, but at some point we're gonna start seeing alpha-synuclein in their system. And then at some later point, we're going to see evidence of dopaminergic neurodegeneration. And at some point along that trajectory, we're going to see clinical signs and symptoms. And then eventually that's going to lead to functional impairment. And again, currently the staging system, it's just qualitative and conceptual. There's no operational definitions. And it appears, I don't think these exist yet. It sounds like they are kind of being worked on. So finishing up with some commentary on the 2 new systems. So this is kind of this was from Darwish and is a overview of how the 2 compare. So we have the NSD ISS in the first column and the Synergy in the second column. So they're both looking at a biological definition of Parkinson's, so using a non-clinical means of measuring Parkinson's. There's not a specific classification within NSD ISS, and with Synergy there is. There's a staging system within NSD ISS, and there's not within the Synergy. The disease label for NSD ISS, they're lumping together all neuronal alpha-synuclein disease, which is Lewy body dementia and Parkinson's. And then for Synergy, they're really sticking with Parkinson's. The genetic variants and the other key components, I think the general gestalt is NSD-ISS is much more selective in what they're picking. So for fully penetrant, they only say this rare SNCA variant. Synergy has several, and then they variants that cover substantially increased risk and associated with clinical Parkinson's with alpha-synuclein, they would not fall in this category. So if you had one of those disorders that results in Parkinson's disease, but you don't have alpha-synuclein, you wouldn't be in the NSD-ISS categorization. You'd be in your own separate path, which is yet to be defined. And then for measuring alpha-synuclein pathology, they only endorse the CFS seed amplification assay, and Synergy endorses a few others. And then for neuronal dysfunction, they only endorse the DAT scan in NSD-ISS. And then for Synergy, they look more at neurodegeneration and endorse both the DAT scan and some other measures as well, the MIBG and the SPECT. And then clinical signs and symptoms are used to diagnose neuronal alpha-synuclein disease. And it's not really used that much with Synergy because the clinical is kind of separate. And then the purpose of the clinical signs and symptoms to distinguish stages with increasing functional impairment, so looking at progression over time. And then for the Synergy, it's more just telling you, is this Parkinson's or is it not Parkinson's? So the MDS, again, which is the Movement Disorder Society, they came out with a statement on this, and the basic take home is that there's a need of a wide international consensus to stage or classify PD with involvement of clinicians, basic science researchers, persons living with Parkinson's, other stakeholders, including regulatory agencies and pharmaceutical. The regulatory agencies and pharmaceutical companies are really an important component of this, because a lot of the thought with this is if we can identify things sooner before people are developing overt disease, we could intervene and have greater success with things. So we have to figure out how we're going to identify it sooner, and we're going to define that in order to do those trials and look at things. They bring up some concerns with alpha-synuclein as a marker. This is universal, and I'll present 3 commentaries. This is universal across, that there's some concern with that. They feel like there's no reliable way to know which clinical syndrome someone develops. So you can tell someone they've got alpha-synuclein, but does that mean they're going to get dementia with Lewy bodies? Some of them, it may even be that you would be telling them they're going to get multiple system atrophy, or are they going to get Parkinson's? There's no means to quantify it over time. A sizable group of persons with Parkinson's don't have alpha-synuclein, especially in some genetic cases, and it doesn't actually reflect what's happening in the brain. So this is synuclein in the periphery that is not in Lewy bodies yet. And we don't even know what synuclein does. So there's a lot of issues with synuclein. And then most of the assays, as I just said, don't distinguish multiple system atrophy from Parkinson's. So that's definitely a negative there. Comments on the staging system. So they comment first on the current staging system, saying there really isn't one. The staging system we have in terms of Hone and Yar doesn't really classify by what you would call a staging system today. And it's really limited in that it only reflects motor symptoms, not non-motor symptoms, and doesn't do anything to cover preclinical phase at all. And then they say that the landmarks proposed for new staging system have not been proven to be predictive of future disease progression or events. Sounds like some, and after I gave this talk on Wednesday, talked to somebody involved with a study called PPMI, and it sounds like a lot of this data for the development of the Simuni system has come from PPMI data. So they do have some, data that they were working with in terms of development of things. Any new system needs to be studied and recommended as an recommended evidence-based consensus method. Be used to develop such a protocol, so that anything that's proposed really needs to be studied before you move anything forward, and a new system should just start at a research level. And this is agreed to again across the board in the commentaries, and it's even stated in the proposal of these systems that these would be research level to start and shouldn't go to clinical. I think, however, there's a big concern that jump often happens before people want it to. So I think that is a place where we really need to be cautious. And then this is another commentary from Darwish et al. Has the time come to redefine Parkinson's disease? So they comment that they welcome a new framework as an existing research opportunity. So again, really focusing on research. They raise the question with the idea of labeling someone with a disease that doesn't have symptoms. So they kind of worry about this, 0 stage, that you're saying someone has an alpha-synucleinopathy when they don't have any symptoms of anything. And we know that there are a lot of genes that aren't fully penetrant. And what does that mean in telling someone that they have some risk, but we can't say the risk is super high. Feel that limiting just to Parkinson's rather than lumping together Parkinson's and LBD is preferable. And they worry about some erroneous diagnoses with the synergy having a low bar for some of the component pieces. They feel strongly that the terms Parkinson's disease and Lewy body dementia should not be abandoned. Again, the limitations of alpha-synuclein. Not all persons with Parkinson's or Lewy body dementia have alpha-synuclein, so I think everyone kind of worries about this group. And there have been postmortem studies, so after people have passed, studies that have shown alpha-synuclein in persons without clinical symptoms. So are we just going to be worrying people who aren't going to go on to develop clinical symptoms in their lifetime? They feel like there's not currently enough evidence to support a disease staging system, and really worry about the risk of the criteria being used prematurely. suggests that after more study, it will be appropriate to integrate the criteria into one unified system. So it's likely it won't be either of these, but maybe some combination of the two. And then this is the last commentary that I'll talk about. And they're a little bit more forthright in their opinion that Parkinson's disease is a recognizable and useful clinical entity, useful diagnostic entity. The clinical concerns that clinical disease is not at the forefront. That's like kind of a, back in the 5th page of the article that either of them talk about clinical stuff. The concern that many aspects of Parkinson's aren't related to alpha-synuclein, and these aspects could potentially be lost. That lumping everyone together suggests that there's just one disease path, but we know that this isn't the case, and there's a lot about where the Lewy bodies develop, and that's different in different disorders. So they kind of worry that we're losing that a little bit, and worry again about moving to clinical practice prematurely. Again, the concern with alpha-synuclein is biomarker. They do not feel that synuclein is validated enough as a biomarker. Don't feel that there's enough evidence of reproducibility. Don't feel that it's the sole origin or serves as a good marker of progression of disease. They note that there are more than 100 other proteins seen in neuropathological inclusions, and we're kind of just focusing on this one that we don't, even know what it does. And that we see this damage in different parts of the brain, and this isn't explained by just looking at alpha-synuclein and where the damage is going to happen. So their conclusions that Parkinson's is a recognizable and valuable clinical pathological entity. The attempts to redefine are based on inadequate and partial assumptions, and there's unintended outcomes for incorrect assumptions. Both proposals are interesting and valuable as academic endeavors, so they kind of even push this, I feel like, a little bit further back of where the starting point is. They do feel like the new systems will trigger discussion about mechanisms and therapeutics, and then they end kind of on a high note and say both proposals are highly welcome. So that's like their one, I think, positive statement in the review. This is my own pictures that I put in, but I think when we think about Parkinson's, there's faces that come to mind, people that come to mind, and it certainly, I think, to abandon the term would have some major consequences, and maybe one of these a picture is worth 1,000 words. I wanted to do some talk on DEI before I wrap up with my feelings on things. One of the pieces I think that we always have to think about with DEI and genetic studies is whose genetics are we looking at, right? If we've got all the high-risk genes that we know of are in European populations, we're leaving out a lot of people in the system. So this was an article from 2022 showing different areas of the world and the number of publications. The authors are from these places, so this isn't like totally ideal, but definitely you see that there's huge variability from the dark blue having loads of publication, and then the light green having one, and then the grays seeing none. So we do just have to be careful whenever we're thinking about genetics that we're including everyone. And then this was from Cardoza. This was the MDS comment. I really liked this statement that these systems open up the possibility of creating a highly undesirable two-tiered diagnostic and staging system for Parkinson's, dictated by access to technology, limited by geography and expense. So if we're talking about you need to have this alpha-synuclein testing, you need to have these specialized scans done, much of the world is not going to have any access to these things. So it's like they can't even, get on the train, so to speak. So I think this is something we really have to keep in mind, and in thinking about development of things too. Can we develop easier assays, cheaper assays, ways to do things that we can reach more populations? So my thoughts, it is appropriate to discuss and think about these ideas. I think there's benefits of looking at genetics and pathological basis from a research perspective, especially look at targeted therapies. I'm not sure, however, that these systems are going to accomplish that. I think even by the time we're getting to alpha-synuclein testing positive, some things happen to cause the alpha-synuclein to be developing that we don't understand. And the genes are very different for different variants of where the path is on that. So I think like we kind of even need to go back further if we're really looking to look at targeted therapies. I think genetics may be a good point for that, but I think these bigger staging systems, we might still have a lot lost there. I worry that some of this is just driven by a new tool. You know, this new alpha-synuclein measurement came out. Let's figure out how to use it. Knowing sooner, we always hear is, oh, that'll be better, we'll do better. You know, we've known the gene for Huntington's for quite a few years, and we haven't figured out a cure. So I don't know that that's always the case. I think they talk a lot about the negative effects of someone knowing they're at risk. I do think there can be positive effects of knowing someone's at risk. And the person who spoke, who was a PPNI investigator with me on Wednesday, was saying, you know, she was really surprised in working with patients because this looked at people who had smell issues and then abnormal DAT scans before they were having clinical symptoms. And that patients were very comfortable with the uncertainty, that they kind of got that. It wasn't a big deal. I think also when something's tested positive, our behaviors can change dramatically. I think COVID was a huge example of that, right? Like when you had the sniffly nose, but you couldn't get a COVID test, did you really isolate? Did you wear your mask all the time? When you had the positive COVID test, you shut the door and stayed in your bedroom, right? So would people do things like aggressive exercise regimens, changing diets, things like that, that we know that can have some beneficial effects if they knew they were really at high risk of going on to develop this, as opposed to if they think they're at a 2% risk, 3% risk, like the general population. I do think from a patient perspective, oftentimes symptoms are really important. And I feel a little bit like we're losing that focus a bit. Maybe that's just not the place of this, and there's other things that can focus on that. But I think I do agree that we're really putting symptoms as like an afterthought. And oftentimes in terms of managing the person in front of you, if you can get their constipation under control or get them sleeping better, that can be really, really life-changing. And we don't want to lose thought on that. So I'll wrap up with my last snow picture. These are my kids. This is an older picture, but this is, I think, the world's smallest snowman. We actually don't get a lot of snow in Portland. That's Mount Hood in the background, where we do get a lot of snow. There's a glacier, so there's snow there all year, but within the city, we don't get too much. And my kids managed to make a snowman with very little snow. I think this is probably also a representation of where the staging systems are these days. They're these little tiny snowmans in their infancy, and over time they may become much more developed and much bigger and have much more implication and use for practice, but we're not quite there yet. Oh, and I wanted to thank Dr. Gupta as well for inviting me, for sharing his dad's story. It's time for questions.
Thanks for a wonderful thought.
I don't think so.
All right. Anyway, I can go.
I can repeat too. So
Thanks for a wonderful thought. I'm not as up to date on that. Some of them recent genes I'm just curious, are they implicated in Deepak pathways? Like some of them are not implicated in at all.
correct. So he was just asking, are some of the genes that are identified in alpha-synuclein pathways, or some of them not at all? So some of them are not at all. And I remember, like, as a fellow being like, okay, you make a diagnosis of Parkinson's definitively by seeing Lewy bodies, and then being like, asterisk, there's a subset of Parkinson's patients who don't have Lewy bodies. And I was like, but how can they have Parkinson's disease if they don't? So there is a subset where they do not have Lewy body pathology, but clinically fit the picture of Parkinson's.
Like, associated with specific clinical phenotypes, like this group different symptom, like big
Yeah, some do. So, for example, age of onset, we see some that are much more seen in people with young onset, some that tend to be more of a typical picture of a idiopathic Parkinson's patient. Some symptoms that can be more predominant. There's still within most of the genetic ones, some variability in that, but sometimes it does follow a more tight trajectory. And then in terms of what the genes are doing, it's very variable in what the mechanism. They fall into buckets, which I don't know all those buckets well enough off the top of my head, but it's not all about alpha-synuclein.
That's okay. Thank you. That's great, Doctor.
Thank you.
This is not my field at all, but I know said pharmaceutical companies are investigation stage. And you said that the patients are worried about what I'm getting. I guess I wasn't following.
Oh, I mean, I think just the community is worried, like, where are we kind of focusing our efforts? And so the idea is, like, we want to, I think from a research perspective, there's a lot of benefit to going earlier, right? Where you could prevent disease onset maybe. But I think you just worry if too much energy goes to that and not enough energy goes to treating the person in front of you, is something lost in that. And I think Huntington's, again, is a good example of this, of, all these studies have been done in very early stage, and yet half of people with Huntington's spend their life or their disease time in the late stages, and we have like almost no studies focusing on how to make that better. So I think, it's just kind of where our energy is going to go. And are we gonna, if we're putting a lot of energy in this very early stuff, are we gonna forget about trying to treat the person in front of us and understand better how to manage that, if that makes sense? I don't think it's necessarily an either or. I think it can be an and, but I think that's one of the things that people worry a little bit about.
So that very insightful talk. Some questions. The first one is that, if I remember correctly, gave the sensitivity and specificity of the first for diagnostic method. Do we have that for the original components of that?
Yeah. So the sensitivity and specificity is for the clinical diagnostic criteria that we currently use. So, and then there is separate sensitivity and specificity available for a DAT scan for alpha-synuclein testing, with some caveats, like a subset of people are not going to test positive for alpha-synuclein because they're going to have one of these forms where they don't have alpha-synuclein. So it's kind of complicated, but the sensitivity and specificity is decent for DAT scans and for the seeding amplification with alpha-synuclein CSF.
Once you work the diagnosis, the system, how do you validate? What is the logic of the diagnosis?
I mean, I think that's hard to say, right? And so I think thankfully there has been this PPMI study that's trying to follow people in these earlier stages and see what it actually looks like. But I don't think we yet know what are these cutoffs going to be and where do they land, and there is still a lot to do. And part of the reason I think the Hoehn-Yahr has been around for decades and decades is because it's complicated and no one's come up with a better system. And I think there's also the issue of we are focused on early, and we're not well defining what does Parkinson's look like in the later stages. And we don't have great ways to have someone come into us and say, oh, here's what is going to happen in 5 years to you, or here's what's going to happen in 10 years to you. We don't really have that data that we can explain.
I don't know if the question's going for, but if you had patients that have patients that's modality or it all constantly staff created a product, right? Item. And then regardless of where you go far, you plug in item and bring the confidence in the change.
Yeah, so that was a question about DAT scan and then autopsy and then looping it back. One of the difficulties with autopsy confirmed things is it's so many years later usually, and then you're not having a DAT scan done unless we think you have Parkinson's. So, and then the DAT scan doesn't clearly quantitatively change over time, so we can't use it as a measure over time. And people are trying to do things. We have a researcher at OHSU in the Portland VA who's looking at people who currently have a diagnosis of Parkinson's and then going back and getting their pathological specimen from their colonoscopies that were done a decade before, 5 years before. So I think you can work backwards sometimes, but it's pretty hard to work forward. And the earlier you try to get, the harder it is, you know, to get to that endpoint. Yeah, and there's a lot of Parkinson's, but there's not enough that you can also just take a bunch of people. And PPMI tried to do that with, you know, they called it an enriched sample. So taking people who had smell problems and then doing the DAT scan and then seeing what happened. And I mean, eventually, and probably already, a number of those people have gone on to autopsy, but you know, that number is going to get smaller and smaller the further you go from that initial testing.
I was just to say, I think what's tricky is there is this driving force trying to identify hospital at to also might be going to identify our team. Makes sense to start defining as early as possible. Not necessarily that they have some that you're allowing them to get by the time we're less likely to be productive. But I understand justification. We're all trying to figure out how do we apply this in practice.
And and so Jim was just saying there's again a lot of back and forth, and you want to identify early because those are the cases for these clinical trials where you think we're going to potentially be able to be helpful. But in your clinic, you're going to be seeing a lot of people who are stage 3 already and kind of who cares, right? Going backwards. And I think that's it. I mean, I think for research, this is really appropriate. And for there is that concern that we're going to.
I think people really need that very graphic. Need it because it's a variant, but clinically or not progressing the way you expect it to. I think the tools are great. Where it's interesting is when you have something look hard to you and you have a negative DAT scan, then you have the negative skin biopsy. At what point do you decide to have a rough diagnosis?
Oh, I will close by just saying thank you and very nice talk. And I'll I believe they're really even at research level in my opinion also at this point. And I think it goes back, reminds me of Dr. Van's comment, like Parkinson's disease is just not one disease. And I wonder whether in these academic endeavors we are trying to contain different diseases in one framework and not really getting anywhere. Like it doesn't even acknowledge the very fundamental Parkinson's dichotomy with tremor versus without. Like it doesn't even explain that. So it links with like, are we a comment you made, like the clinical presentation has been put at the back burner. So like all in all. But thank you so much. It was very helpful and I hope you enjoyed. Thank you.